So tonight we're going to talk a little bit about this. This is an adjunct for most of us. So we're going to talk about pain management, but from a what I call the hormone-centric lens. And these are folks that are frequently have chronic pain. They've been on opioids long-term disabilities, and they're just not getting anywhere. And so I thought it would be useful to take a look at what happens to hormonal imbalances with patients with chronic pain. And I came up with some pretty startling discoveries. So I hope you find this useful. And of course, we'll have questions and answers afterwards. And if anybody has any comments, they're always welcome also. So since we are doing CMEs, we need financial disclosures, no relevant relationships. In the chat is the link that you can use to get the CME credits. It's $30 for 2 CME credits, and it's basically 4 or 5 clicks. It's very, very easy to do. It's not complicated at all. And one of the holdups for when we were trying to figure out how to do this was that it was a lot of paperwork, but the folks at Michigan who running this thing had made it quite simple. 2 CME AMA CME credits. Nurses can get 0.2 cc's of CE credits. Anybody else who needs a certificate, let us know, and we'll get that to you. Okay, so again, being CME, we're going to look at objectives. We're going to look at pain as a stressor. Why test hormones? Why bring this up at all? Which patients are candidates for hormone evaluation? We're going to talk about neurosteroids, which are hormones that are generated in the brain, independent of the periphery, where we normally think of them. We're going to talk about the 6 major, 7 minor hormones involved with pain management. We're going to take a look at each one individually. We're going to look at biomarkers at the end, and also we'll look at inflammatory markers. So it'll give you an idea of what to look for. And when we talk about inflammatory markers, cytokines, it's also helpful to look at it, and we can get an idea of what over-the-counter herbal remedies and amino acids and vitamins might be helpful also. So we'll take a look at all of those things. And I hope this is, again, this is not a primary look at pain management. This would be a secondary look. And this is, if you're not familiar with hormone optimization, this is not a basic class. This is more advanced. I'm not going to go into a lot of the details of hormonal, optimization, but we're going to skew everything towards pain. Remember last week, somebody I think it was Dr. Farshian's lecture, was asked about LDN when we were talking about over-the-counter remedies only. So we're going to look at hormones through a pain lens. So again, why test hormones? So they're actually an independent marker for uncontrolled pain. It indicates hormonal deficiencies, insufficiencies, and excesses. It acts as hormones act as an independent monitor for pain recovery, and it points to hormonal issues complicating pain management. So there's good reason to take a look at these. And like I said, we look at them specifically patients who have chronic pain and that are not getting any better, and we're not getting anywhere. So pain as a stressor. Severe pain results in pituitary adrenal axis disruption. It's a sustained opioid pain control actually diminishes the pituitary's gonadal adrenal function. You'll end up with initially an increased cortisol and then a decreased cortisol, and we'll have uncontrolled pain and opioid use. We're going to find out that opioids induce an endocrinopathy. It decreases LH and FSH. It lowers testosterone levels in 75 to 85% of patients. It will end up with patients with lower estradiol levels. Females that are premenopausal end up with oligomenorrhea and amenorrhea. Males will exhibit gynecomastia and impotence. The hormones that are involved mainly are HCG, growth hormone, testosterone, pregnenolone, looks like I spelled that wrong, progesterone, androstenedione, and DHEA. These are the main hormones that are involved with pain control and pain management. And we're going to take a look a little bit at HCG, which is thought to be the pregnancy hormone, but it turns out to be that it's much more than that. So hormonal modulation of pain. Remember, the hormones that are involved are insulin and thyroid. That regulates cellular metabolism. Pregnenolone, progesterone, and cortisol mediates healing and inflammatory responses. Androstenedione, DHEA, and testosterone, these are your androgens or anabolic tissue regulation. Growth hormone, HCG, and cortisol deal with cognitive function. And growth hormone, HGH, HCG, testosterone, pregnenolone, progesterone, androstenedione, and DHEA have some involvement with analgesia. The one that's best known is testosterone, and it's not infrequent that we have patients with low testosterone, and when we bring them up to an optimized or adequate level, they'll frequently tell us that their aches and pains, joint pain, and chronic pain syndromes are diminished and sometimes even gone. So let us move along. So before we get into the specifics of each hormone, I want to discuss this concept of neurosteroids. So neurosteroids are hormones that are manufactured regionally in the brain. They're produced by and act on the glial cells and neurons. So even though we get a measurement, say, of testosterone levels or thyroid levels, there's a certain amount of it that is generated in the brain independent of the periphery. It follows the same steroidogenic pathway as peripherally generated neuroactive steroids, and they regulate the excitatory inhibitory balance of the neurotransmitters, particularly glutamate and GABA. They act as microhormones. They fine-tune the peripheral macrohormones. You need sufficient GABA levels for calmness, to relieve anxiety, reduce stress, improve sleep, and they are neuroprotective, and they stabilize mood disorders. So this is a different look at the steroidogenic pathway, and the classic one where the hormones are generated usually through the liver, beginning with cholesterol, and it's conjugated into pregnenolone. And this is the classic pathway. It goes to the right here, and it will generate into DHEA, androstenedione, androstenediol. Testosterone will convert to dihydrotestosterone. Remember, dihydrotestosterone is your sort of super testosterone characteristics, and is converted by 5-alpha reductase, which is the enzyme that converts testosterone to dihydrotestosterone. And remember, your finasteride and dutasteride, your 5-alpha reductase inhibitors, block this enzyme reaction here. And remember, again, testosterone, it's not on here, but will aromatize to estradiol. And when you block this enzyme here, certain things happen as things sort of back up. Testosterone will increase, as will estradiol. And that's sort of, those are by up to 15% with a 1 milligram finasteride dose. And that's the dose we use for young guys, young men, 18 to 43, who are trying to preserve their hair. What was either overlooked, was known about and forgot about, or tried to be hidden, was that at the same time, pregnenolone will convert to progesterone. Progesterone will morph into 5-alpha dihydroprogesterone, which will convert into allopregnenolone. Allopregnenolone is the hormone that will stimulate or generate the neurotransmitter GABA, which is your calming neurotransmitter. Now, what was either overlooked or hidden, depending on your look at things, is that when you block 5-alpha reductase inhibitors, when you use 5-alpha reductase inhibitors and block this enzyme here, you're also blocking this enzyme here. And what happens is you end up blocking allopregnenolone, and you end up with an overload of L-glutamine, which is your activating or your agitating neurotransmitter. And there's a small but not insignificant subset of, again, young men who have end up with can be severe psychiatric illnesses due to this blocking of this 5-alpha reductase in this pathway here. It's about 1 to 1.5% of the patients, which you say, well, that doesn't sound like a whole lot. But in 2019, there were 19 million or 11 million prescriptions written for 5-alpha reductase inhibitors. So 1.5% of that is about 500,000 cases. So you know, if you look at it that way, that's a you know, quite a high number. Okay, somebody, if you could mute yourself there, please. Thank you. Neurosteroids are the hormones that cross the blood-brain barrier. And again, like I said, they regulate those neurotransmitters, and they produce analgesia through the regulation of GABA and MDA. They also suppress neuroinflammation and promote neuroregeneration. Failure of this system results in erratic brain transmissions, and it's expressed as depression, suicide, anxiety, panic attacks, phobia, and psychosis. So, you know, an intact blood-brain barrier, an intact hormonal system is crucial for adequate, mental control. Here are the neurosteroids that are involved, and the ones that we're going to look at are pregnenolone, progesterone, estradiol, testosterone, and then glucocorticoids or cortisol. Also involved is allopregnenolone, and I've spoken a number of times about the synthetic allopregnenolone that's been developed by one of the major pharmaceutical companies that's used for postpartum depression. It has an FDA approval for. Unfortunately, has a side effect of sudden loss of consciousness, which in the oral form, if someone's driving and has a sudden loss of consciousness, can be quite disastrous. So at the moment, it's only approved for intravenous use postpartum. It's a 60-hour treatment, an inpatient, and it's $34,000 for the treatment. So it's a little bit impractical. And it's supposed to be at least 60 to 70% more effective than the conventional SSRIs and SNRIs for postpartum depression. There is an oral form that had been held up for a long time in research due to this sudden loss of consciousness, and it was approved last summer in August of 2023 for major depression. And I was curious to see how they were going to get around the loss of consciousness if they'd altered it all. And the answer was no. There's a black box warning on it that says you need to, if you take this, you're prohibited from driving for 10 hours. That's how the company got around it. So it's called Zerolone, and it's it is an FDA approved drug, but it's there are some issues with it. This is just a chart that to show that the neurosteroid, the amount of hormone in the brain is, which I remember mentioned, is independent of the periphery. And you can see here postpartum for progesterone, we got 65 and 137 nanomoles in the brain versus the plasma, which is much less. You can see it's 15 times or 12 times as much for progesterone. Pregnenolone, which we're going to be talking about in the luteal phase here, is in the plasma is 15 and the brain is 100. So you can see it's much more concentrated. So the functions of the neurosteroids, and the reason I'm bringing all this up is that this neurosteroids play an important part in regulating pain management and pain control. Beside the psychiatric issues. So the neurosteroids suppress overactive glial cells and neuroinflammation. They protect the glia and the neurons from cell death, and they participate in neuroregeneration and neurogenesis. The hormones that are specifically involved here are pregnenolone, DHEA, progesterone, and HCG. They've actually been demonstrated in experiments to have some healing properties in severed or damaged spinal cords. Microglia can become activated with persistent pain, which results in neuroinflammation. Glial activation causes pain centralization and sensitivity, and the centralization causes pain to progress from an intermediate or mild to moderate state to one of severe constant pain. This is sort of a schematic of what happens. You have an injury here. You stub your toe on the bed frame. Oh, you get a pain signal that goes to the it enters the brain and goes to creates a centralized pain signal. It activates the hypothalamus to release corticotropin releasing hormone, gonadal releasing hormone, and thyroid releasing hormone. So we get all three, and these all happen simultaneously. The corticotropin releasing hormone activates the pituitary to produce cortisol, pregnenolone, and DHEA. The gonadal releasing hormones stimulate the pituitary to activate FSH and LH, which stimulate the body to make testosterone and estradiol. And the thyroid releasing hormones stimulates TSH to make T3 and T4. So they all happen all at once. These are the hormones that are involved with this pain regulation. And the hormones that we're going to screen, the major ones, remember I mentioned there were 6 major and 7 minor, and these are the hormones that we're going to look at is cortisol and ACTH, which is technically not a neurosteroid, testosterone, pregnenolone, progesterone, HCG, and DHEA. The minor ones for pain, now remember it's pain, it's not that thyroid is a minor hormone, but it's pain. Remember, it's thyroid. Remember, vitamin D, we consider that a prohormone because it acts on cortisol and growth hormone. Prolactin, oxytocin, IGF-1, which is the activated or useful portion of growth hormone, estradiol, and nandrolone, which is a synthetic. So hormonal reactions acutely, we get serum rises in testosterone, pregnenolone, ACTH, and cortisol. But in chronic pain, the same 4 hormones will decrease, will be decreased. So there's a difference between an acute state and a chronic state. Which patients should be screened for it? Those that are in constant unrelenting pain, those that exhibit or are claiming a disability, and those that are recluse, become reclusive, those with severe insomnia, medication seekers, early refill requesters, family members that have sort of thrown up their hands and say they don't know what to do with their loved ones, those that have anorexia, chronic severe depression, crying spells, and hopelessness. And there's a certain subset is always looking for the next cure. So this is sort of a little thought of way to go. And again, we're not going to get a quote unquote cure here from somebody with chronic pain, but we will get some improvement and a better quality of life. So outcomes, so these are studies that are outcomes of short-term pain relief with hormone optimization. So short-term, we get resolutions with hormone and fluid levels can be resolved quickly. The chronic pain syndromes, we end up with high cortisol output continues until the cortisol or the adrenal axis becomes exhausted of all reserve, and then the cortisol and pregnenolone levels will become diminished. So you have to know where you are sort of in the pain cycle of the patient. If it's early on, we're going to find higher cortisol levels. If it's late in the game, 3 years, 5 years, 10 years down the road, these levels are going to be quite low. When pain is extinguished, hormone levels theoretically should return to normal. Unrelenting pain can lead to a vegetative state, and you need to check cortisol levels. Cortisol levels less than 1 microgram per deciliter is a medical emergency, and patients can expire with very little to no cortisol levels. The symptoms would be weakness, fatigue, a blank stare, slow movement, lethargy, bedbound, very apathetic, not moving, hypotensive, tachycardia. This is a cortisol emergency. The vegetative state is, again, a blank stare, low blood pressure, high pulse. The patient moves, talks slowly. They appear to be, intoxicated or drunk. Movement causes pain. They take to their bed. They become severely fatigued, lethargic, and weak. And the treatment here, you want to give them opioids. You want to get them out of pain. You want to give them fluids. You want to check their cortisol levels, and IV steroids are necessary for to relieve this condition. The opposite is we get a breakthrough hypercortisolemia, and in tissue degeneration caused by excess cortisol results in what you see here: depression, psychosis, glaucoma, peptic ulcers, hyperglycemia, diabetes, hyperlipidemia, abdominal obesity, hypertension, thinning skin, osteoporosis, immune suppression, dementia, and mental health abnormalities. These are biochemical alterations caused by cortisol. The most common ones are the ones you see here: hyperglycemia, hyperlipidemia, immune suppression, osteoporosis, and brain atrophy. So this is kind of a summary of the function of cortisol, stress hormone, is your fight or flight. This is we're coming around the rock, and there's the mountain lion, and we're either going to have lunch or we're going to be lunch, and you get that fight or flight adrenaline rush. Cortisol will regulate electrolyte balance. It regulates blood sugar cravings. It regulates the immune system, the effects of stress. It regulates energy production, LH production, and testosterone regulation. Not enough cortisol results in insomnia, fatigue on awakening, intermittent daily fatigue. Now remember, fatigue that is intermittent is usually associated with cortisol or stress reactions. Fatigue that is constant all day long is more of a thyroid issue. And remember, the interaction between the thyroid and the adrenal gland, cortisol, is sometimes quite subtle. And you can take care of one, and without taking care of the other, we don't get a relief of the fatigue issues. So you need to look at both. Digestive issues, loss of sexual interest, poor libido, low blood pressure, low blood sugar, slow heartbeat, sugar cravings, feelings of stress, chemical sensitivities, and allergies. Excess, too much cortisol, sleep disorders, sugar cravings, fat deposits, osteoporosis. You get that buffalo hump on the back of the neck, where at C7. You get fatigue, and again, cortisol is intermittent fatigue, not constant. It increases the blood pressure. We get water retention, elevated blood sugars, high blood pressure, thinning skin, hair loss, and loss of muscle mass. So pretty much kind of the opposite. Okay, so those are the characteristics and functions of cortisol. There's quite a bit there. It takes a little bit of time to get used to it, but there are a couple of tricks and shortcuts that we'll talk about. ACTH is a biomarker of pain. So this is, again, your two standard deviations. 9 to 56 picograms per milliliter is considered normal. You know, we want to play in the middle. So the middle would be somewhat about 25 to 35 would be about dead center for ACTH. It's here pain is controlled, the pituitary is functioning normally, and the patient has a reserve for pain flares. Added pain relief likely not necessary when ACTH is sort of in the mid-range, and there's no opioid and glucocorticoid suppression. When ACTH is low, less than 5 picograms per milliliter, we talked a little bit about that just a few minutes ago. This is long-term pain overstimulation, opioid glucocorticoid suppression, hypothyroidism, and you need, and again, this is your medical emergency. We're going to treat this patient with opioids, sleep medications, anti-anxiety agents, IV steroids, and we're going to make sure we do a monthly follow-up. You want to make sure that they have good pain control, and you know, if there's no change in ACTH after all of this, you probably need to turn it over to a good endocrinologist. High ACTH greater than 60 is someone in severe constant pain and an overwhelming HPA access utilization. Again, opioids, sleep meds, and anti-anxiety agents are going to be your your first line here. You need good, you get monthly follow-up. With no change in ACTH. We want an endocrine evaluation here also. Testosterone. These are the effects of testosterone. We've showed you these a number of times on different organs. Remember, testosterone, I consider your anti-aging superstar. It affects the brain. There are testosterone receptors in the brain. It increases libido, mood, spatial awareness, ambition, and drive. In the cardiac wise, it lowers LDL, it raises HDL, it reduces the risks of heart disease. In the liver, it synthesizes your proteins. Sexual organs, secondary sex characteristic growth in males, penile growth, spermatogenesis, and sexual pleasure. Bone marrow stimulates stem cells. Bones increases bone density. You get an increase of up to 2% on your DEXA scan in the hip and in the lumbar spine. With adequate testosterone, muscle growth, muscle mass, and volume will improve, and the kidneys will stimulate erythropoietin production, red blood cell production. Again, I can't emphasize enough, because I deal with a lot of VA patients. When you get an increase in red blood cells from testosterone, it is increased red blood cell production from the erythropoietin and a decrease in a iron protein called hepcidin. It is not polycythemia vera, which is a rare blood tumor, which polycythemia vera is a genetic disease 97 to 98% of the time. And you can tell just by looking at a CBC, if the patient's white blood cells and platelets are normal, and the elevation in testosterone is from the elevation in red blood cells count is from the testosterone. You're not going to get blood clots. We went through this on a couple of other lectures. You're not going to see an increase in strokes, heart attacks, or blood clots from elevated testosterone. So just keep that in mind. A little bit of a summary here. So low testosterone is patients become anxious, depressed, poor libido, poor muscle tone, urinary incontinence for females, vaginal dryness for males, erectile dysfunction, poor sexual function, thinning hair, fatigue, apathy. These patients, they just don't care. They don't have any drive. They have no sort of backup energy. Patients that have adequate testosterone levels and over the age of 60, and adequate with being a minimum of a total of 600, and a total testosterone and free testosterone at least 2 to 4%. It is independently, they will independent of any other signs and symptoms or disease maladies, will live on average 12 years longer than patients that have consistent testosterone levels less than 600. So excess testosterone, we hear about aggressiveness, and we see it once in a while, but not very often. Normally it's oily skin, oily hair, acne. You'll get skin breakouts on the neck and shoulders. They can get redness in the face. You can get a little bit of higher blood pressures, peripheral edema. I don't really see voice changes in females very often, and I don't see, every once in a while someone, they'll say they got somewhat aggressive, but there's usually it's a poor balance between testosterone and estradiol. When we balance those out, the aggressiveness seems to go away. The so-called road rage, again, it's not something that we see very often with testosterone, optimization. Just a couple of studies that deal with pain, testosterone, and rheumatoid arthritis, with going patients from the lowest to highest quartile of testosterone. So depending on what scale you're looking at, one major lab says it's 264 to 916. Another major lab says 250 to 1100. So going from the lowest quartile to the highest, patients with rheumatoid arthritis have a 21% on average improvement versus 4% with placebo. Bone density, as I mentioned before, we get an increase in bone density with adequate testosterone of anywhere from 1.8 to 2.2% in the lumbar spine, and anywhere from 0.5 to 1.8% in the hip. So we get an improvement in bone density. And for females, just to let you know, we will get 92% of the patients will cover their hot flashes, night sweats, and brain fog with adequate testosterone. If they can't use estrogens, or we don't want to use estrogens, or they don't want to use estrogens, with testosterone alone. Testosterone propionate, which is a short-term testosterone. This is it has a 36-hour half-life. 10 milligrams IM 3 days before menses will have a 92% improvement in dysmenorrhea, so pain from menses. Lichen sclerosus will have a 66 to 90% improvement in symptomatic response. Usually here we'll use a testosterone cream right on the affected tissue. And lichen sclerosus, of course, causes painful intercourse, defecation, intense vulvar pruritus, excoriation of the vulva, loss of vulvar structure, fusing of the labia, and covering of the clitoris. So we get a very good improvement here. We've also done a PRP for this, and we've also done PRP with exosomes and testosterone. And we get about a 90 to 95% response rate for using all of those. A couple of novelties, we talked about chronic pain with fibromyalgia, or chronic pain with adequate testosterone, pain from fibromyalgia, low back pain, neck pain, joint, elbow pain, knee pain, wrist pain, ankle pain, have all shown 30 to 50% improvement with adequate testosterone levels. Opioids have a direct effect on the pituitary and the testes. And when adequate opioids are on board, we get an increase in prolactin, a decrease in LH. Remember, LH, luteinizing hormone, stimulates the Leydig cells to produce testosterone. FSH, we get a decrease in FSH, and FSH stimulates the Sertoli cells to produce sperm. So we get a decrease in spermatogenesis. We get a decrease in testosterone with adequate opioids. So patients that are on long-term opioids are going to have low testosterone and low testosterone symptoms. And the prevalence ranges from anywhere from 20 to 80% of patients with adequate opioid pain control will have inadequate testosterone levels if they're not looked at. Testosterone concentrations drop more than 50% within a few hours of taking an opioid. So this happens rather quickly. 87% of the men with adequate opioid usage experience new onset erectile dysfunction, and 52% of females experience sexual dysfunction also. And again, you're going to have deficits in LH, FSH, and the androgens. And remember, the androgens stimulate or aromatize to estrogen. So it's sort of a cascade of one feeding the other. So adequate opioid pain control you'll end up with a poor hormone optimization also. Certain opioids have a direct effect on the pituitary and testes, and other opioids have a direct effect on estrogens, fertility, and libido. And so the opioids that have a direct effect on the pituitary and testes are hydrocodone, oxycodone, and morphine will reduce free testosterone. But the hydrocodone, oxycodone, and morphine, and also pregabalin, have no effect on estrogen. So you need to pay attention to which opioids you're using for which patient. Methadone, fentanyl, tramadol, and non-opioids, gabapentin and pregabalin, have no effect on the pituitary and testes, but they have a significant effect on free estrogen. So, for your males, you want if you're going to use opioids, methadone, fentanyl, and tramadol are your go-to here. For females, it's hydrocodone, oxycodone, and morphine. So I'm going to have to make a little note of that until you get that settled. Here are some therapeutic options for low testosterone, and I forgot. I thought I had taken out all the brand names, so we'll go through them. So clomiphene is a SARM. It is it's not an androgen per se. It will stimulate the testes to produce testosterone, and we can use it in a 50 milligram tablet anywhere from 2 to 5 times a week. On average, a 150 milligram tablet will increase testosterone levels within 6 to 8 weeks by about 50%. So 2 50 milligram clomiphene per week will double or increase testosterone levels by about 100%. It's pretty how do I want to say it? It's pretty reliable. You can pretty much bank on that. The synthetic commercial products are somewhat reliable. They're in my mind rather weak. We usually start in men at 10% cream, and we'll use a half to a gram a day. And the IM testosterones are more reliable, and usually we'll use them either once a week or we'll split the dose twice a week. The cypionate has a 12-day half-life. The ethionate has a 10-day half-life, so you need to keep that in mind, how much you're going to how much you're going to dose them. Testosterone pellets, I know some of you don't like them at all. Some of you love them, and there's all in between. On average, males will utilize about 10 milligrams per day. So a dose of 1,200 milligrams should, on average, last the patient about 120 days or 4 months. And for females, it's 1 milligram per day. So, that's a fairly standard dose there. So, for females, 100 milligram pellet should last about 100 days, so a little bit over 3 months. Again, the male's about 10 milligrams per day. I don't really like the lozenges. There are some newer products out. There's a pill form testosterone undecanoate that's not supposed to be conjugated through the liver, and it's longer acting. They're extremely expensive. Until the price comes down, I don't really see a need for them. There's a nasal spray, but you have to use that 3 times a day. You do get some nasal stuffiness, and again, it's $800 a month. So again, they're way too expensive. You can get compounded ones that are natural for much less. Most of the commercial products are synthetic, and you will see a lot more reactions from them. And as far as we talked a little bit about increased red blood cell count. So the testosterone creams, transdermal testosterones, about 15% of the patients will get a rise in red blood cell count with the transdermal creams. The IM form, about almost 50% of the patients will get a rise in red blood cell count from that. And it can be anywhere from 7 to 30% from baseline. Pregnenolone, when you think about pregnenolone as the hormone of memory. And you can pretty much leave it at that. We'll go into it a little bit more. Remember, pregnenolone is what cholesterol, which is your base that all of the hormones come from, at least the sex hormones come from, morphs into. And then pregnenolone will turn into progesterone. We talked about the dihydroprogesterone here, and it will turn into cortisol. If you don't have enough cortisol, if the patient is stressed, you will get this, what is known as a pregnenolone steal syndrome. It will steal the substrate of pregnenolone from all of the other hormones, especially the sex hormones, and to make cortisol, which is your fight or flight and your first line of defense. So pregnenolone blocks the effects of cortisol. It is a GABA A receptor antagonist, and it's critical for memory. We see with adequate pregnenolone levels, we get neuroprotection, we get improved mental alertness, we get enhanced memory and cognition. It is a anti-fatigue and improves psychomotor performance. It lowers LDL cholesterol and total cholesterol. It is anti-arthritic, it's an anti-inflammatory, it's antidepressive, and it has a mood elevating component to it, and it has it helps with stress. Doses are usually 50 to 100 milligrams, and it's fairly inexpensive. You can get a good quality. You can get 90 tablets of pregnenolone, 100 milligrams for anywhere from $15 to $20. So it's not expensive, and it is over the counter, believe it or not. And again, you're not going to see pregnenolone excess unless we do it. We sort of overdose patients. It's pretty rare to see that. Pregnenolone deficiencies, again, memory, anxiety, poor pain control, depression, pessimism, arthritis, insomnia, autoimmune diseases, estrogen dominance, mood disorders, and social phobias. But again, I just want it to be a reflex pregnenolone memory. That's really all you need to know. We do measure this. We measure this on every patient. Our sweet spot's about 90 to 110, and I'm sorry, the units are sort of not in my head at the moment. We can look it up later. But sometimes when pregnenolone levels are low, it does not correlate. So we'll ask the patients how their memory is before we tell them what the pregnenolone is, because sometimes it doesn't correlate. And if they tell me that their memory is adequate and they have a pregnenolone level of 32, I usually leave them alone. I'm not going to force it on them. If they tell me that they could use a little bit better memory, or the numbers are low and they tell me that their memory's poor, then we're going to sort of go for the gold. This is not instant gratification. You're not going to see any change for 6 to 12 months. So you have to let the patients know that this is a long-term thing. But where are they going to be in a year from now? Are they going to be better, or are they going to be worse if their memory's poor now and they have low pregnenolone levels? And that usually resonates. And most of our patients, at least the ones we see, they're motivated and they'll stick with it. And we do see improvements in memory and cognition when we supplement the pregnenolone for a long enough period of time. I don't have it nailed down yet, maybe by the next time, but there's a couple of blood tests, serum tests that have come on board from the major labs. They're still sort of looking at them. So it's becoming easier to measure these things. You can measure pregnenolone levels, but measure cognitive function. So brain-derived neurotrophic factor is sort of the gold standard, but it's difficult to measure. And so there are a couple of sort of proxies for it, and I'll come back later and report at another time. Again, normal range. Okay, so here's the units here, nanograms per deciliter, and the major lab will tell you 22 to 237. That's your two standard deviations. You know, that helps us not at all. 25 is normal, 200 is normal. Again, that doesn't help us, but 90 to 110 is usually where we want to be. That's our sweet spot. For memory loss, like I said, about 100 milligrams per day. Maintenance, 30 to 60 milligrams once we have an adequate level. For patients with low energy and fatigue, 150 milligrams per day. And someone who's having severe anxiety and panic attacks, and especially if they do poorly with medications, and we really don't want to use things like benzodiazepine, so we can treat them with 400 milligrams of pregnenolone once or twice a day for up to 4 weeks. More than 28 days, then we're going to start seeing overdoses here. So adequate pregnenolone, and we're going to talk about progesterone. Remember, that's in the next hormone in the cascade. So about 400 milligrams of pregnenolone and 200 to 400 milligrams of progesterone, and yes, even in men, for up to 4 weeks, will calm the panic attacks. So progesterone receptors are present in the peripheral and central glial cells. Progesterone and its metabolite, remember I showed you that chart earlier, allopregnenolone, are diminished in chronic pain scenarios. And symptoms of low progesterone are agitation, irritability, can't sleep, poor libido, headaches, short-tempered. And then symptoms of too much estrogen. So emotional flatness, osteoporosis, bone loss, excessive menstrual bleeding, slowed thought processes, breast swelling, breast tenderness, and then cysts. In females, the uterus, the ovaries, and the endometrium. So uterine cysts are fibroids, we call them. Ovarian cyst, endometriosis is cysts on the, at least think of it as that concept, on the endometrium, and a decreased HDL. Progesterone functions. It relieves the estrogen dominant headaches. It relieves those cysts that we talked about. It relieves premenstrual syndrome symptoms. It's calming. It improves thyroid function. It relieves. It improves fluid balance, and it decreases the risk of endometrial cancer, fibrocystic disease, osteoporosis, and heart disease. We've had a previous lecture that we've done on progesterone after hysterectomy. You know, those of you who know me, I had an OBGYN background, and we would, give our patients, we would do a hysterectomy. We would tell our patients they needed estrogen, for hot flashes, but they didn't need progesterone because they didn't have a uterus. Well, that proved to be wrong. And that's a whole separate lecture, but we have 22 reasons to use progesterone. The one reason not to use it is because it's not going to get the uterus, which is not present anymore. It's my soundproof office, which is not present anymore, to be able to get ready to be implanted. So, and then, by the way, we used to use Premarin, which was the synthetic estrogen, and we know what a disaster that turned out to be. So progesterone has anabolic and immunologic functions throughout the body, and we're actually starting to look at progesterone for young men who have low testosterone levels. There are progesterone receptors in the Leydig cells and the Sertoli cells to stimulate testosterone and sperm production. We're using 25 milligrams a day of progesterone for that as part of our we don't want to use testosterone, in young men because that diminishes sperm count. Progesterone contains central anti-inflammatory, neuroprotective, and analgesic effects. Progesterone is superior to corticosteroids in treating carpal tunnel syndrome. We use a cream. We use it right on the wrist. In severe pain, we get an increase in cortisol, a decrease in progesterone to inversely related. And so we want to try and reverse that ratio. And you can do it with progesterone. Peak progesterone levels result in a 25% decrease in pain perception. Pain severity and hormone fluctuations. So this red here, this is your pain during your cycle. Here, this is the follicular phase. Here's the luteal phase. Green, remember, this is your progesterone. It sort of meanders on down very low here. And then at ovulation, at the ovulation, it peaks here at days 19 through 21. And as you can see here, here's your pain line. Here's your progesterone line. For the gray here is estradiol. So that is this line here, which peaks here. And you see you get a little bit of a bump here. And then again, there's a small peak here. And then the blue is testosterone here. And throughout the menstrual cycle, and you can see here, you get a bump here in testosterone on days 15 through 17. And you get, again, remember, testosterone will improve pain control also. So you can follow these lines here, and as you can see, progesterone is good at controlling it. Testosterone is good at controlling it. Estrogen, not so much. Here's a dosing schedule for progesterone. It comes in a commercial product at 100 and 200 milligrams. In the bioidentical commercial products. You don't want to use the synthetics. I always tell our patients if they're using a commercial product, we have them look at the bottle when they get their prescription. At least in Nevada here, the pharmacist can substitute, and they can substitute with methyl progesterone. We don't want that. Methyl progesterone, as you know, will be at 5 to 10 milligrams. So we have them look at that. And if it says 5 to 10 milligrams, we tell them to give it back to them. We don't want it. It doesn't happen very often anymore, but it will happen once in a while. There's a rapidly dissolving tablet at 100 milligrams, creams at 50 to 200 milligrams. You can get them. There are any number of companies that will make over the counter. You can get, I've seen it as high as 75 milligrams over the counter cream. Perimenopausal symptoms, 100 milligrams 2 to 4 times a day. For premenstrual symptoms, usually days either 14 or 30 days, 20 to 50 milligrams at a 2 to 5% cream. Put that on 1 to 4 times a day. Tell them, and you be a little careful with it, because remember, progesterone is sedating. If they have vaginal bleeding, 100 to 200 milligrams, usually for about 10 days. It will stop the bleeding, and then if they stop it, they should have a reset of their menstrual cycle within 5 to 10 days. If it doesn't, then you need an ultrasound. You want to make sure that there's nothing there that doesn't belong. Endometrial hyperplasia, 200 milligrams twice a day. Optimal blood levels are a lot higher than you see on the sort of the reference range. 10 to 20 nanograms per milliliter is really optimal. There's breast cancer protection when the progesterone is greater than 9 and up to about 13 nanograms. There's about a 60% drop in breast cancer incidence when progesterones are at those levels. Greater than 13, we get an 88% decrease in breast cancer incidence with actually fairly high doses of progesterone. And I don't have the references for that on here, but I do have them if you want them. HCG is constantly produced in the pituitary in women and in men. It's not confined to pregnant patients. I mean, it's not, you don't produce very much of it, but we do produce it. It acts as a major hormone stimulator of testosterone, thyroid, estradiol, progesterone, and cortisol. It produces androgenic effects. And as you know, we for a long time used HCG as part of, as a help or an aid for cravings and weight control. It consists of 2 units, an alpha and a beta. The beta adrenergic HCG activates cyclic AMP and produces nitric oxide to increase blood flow. The alpha is structurally similar to LH, FSH, and TSH. Doses are to stimulate testosterone, 500 to 1,000 units sub-Q 1 to 3 times weekly. You can also use it 1,500 units twice weekly. We usually do a loading dose of about 3,000 units, and we use this in young men who we want to preserve fertility. You can use it 250 to 500 units sublingually, a liquid 1 to 3 times a week to preserve testicular size and function. 250 units twice a week. Usually we do it if we're treating the patient with an IM injection. We'll do it 2 days before and 1 day before their weekly IM injection. For females, we can do it every third day. We get an increase in energy, pain control, and libido. We get reduced opioid dosages and improved sleep, and it neutralizes the opioid reduction of testosterone. Again, you're going to get a stimulation of LH, FSH, and TSH. So we're going to get an increase in thyroid function, or in thyroid hormone. You're going to get an increase in sperm, and you're going to get an increase in testosterone from HCG. This isn't a package insert, and quite frankly, we've used HCG for a long time, and I always say I've really never seen these side effects, but it is written somewhere. There's contraindications for asthma, breast, ovarian, or prostate cancer. Again, probably if we look into some of those are probably some of the myths that have been perpetuated over time, and seizures. So things like headaches, irritability, restlessness, you may see a little bit of that. Swelling in the hands and feet, gynecomastia, injection site pain are some of the side effects. Again, stimulation, so testosterone excess and thyroid excess would be side effects if you would see them. But quite frankly, like I said, we've used these for a long time, especially on the weight control side, with very little to no issues with them. Next comes DHEA. It's the most abundant hormone in the body, and more so for females than males. It regulates estrogen and testosterone production. It is important for bone health and mood disorders. It enhances immune function. It prevents diabetes for insulin control. It suppresses interleukin-10 derived pain from systemic lupus erythematosus. And this is a dose of 200 milligrams per day for SLE patients. It's neuroprotective. It converts estradiol and testosterone. It was approved in 1952 by the FDA for major depression. I don't know that it was ever repealed. I don't know, doubt it's used for that very much anymore. But again, DHEA is over the counter. It inhibits TNF alpha and CNS inflammatory markers, and inhibits that are inhibiting the production of monocytes, astrocytes, and microglia. Low levels of DHEA are associated with chronic pain and headaches, and DHEA and cortisol are inversely related to each other. So high cortisol levels will usually have see patients with low DHEA levels, and a way to leverage or lower cortisol levels pretty quickly and fairly safely is by treating them with DHEA. So doses for females are 10 to 25 milligrams, 5 milligrams to 25, and for males 25 to 100. DHEA deficiencies, think of it as the same as testosterone, so anxiety, depression, fatigue, poor stamina, poor stress management, osteoporosis, bone and joint pain, and memory loss. The thyroid, acute pain stimulates the production of thyroid hormones, leading to a sort of pseudo hyperthyroid symptom. But severe intractable pain then suppresses the pituitary hormones, including TSH. So severe pain and low thyroid output is usually a chronic pain. It will get what we call a low T3 syndrome or a euthyroid 6 syndrome. These are patients that have low TSH. So remember, TSH 0.8 to 2.0 is kind of our sweet spot. And remember, TSH is an inverse. So TSH less than 0.8 is indicative of hyperthyroidism. Greater than 4.5 is hypothyroidism. Migraines and hypothyroidism are sort of interrelated, and also hypothyroidism and GI symptoms are also interrelated. We can get arthralgias, myalgias, tenosynovitis, carpal tunnel syndromes are frequently presenting symptoms in patients with undiagnosed hypothyroidism. And the first symptom that we see in hypothyroidism, and up to 5 years before the lab test turn positive, and the patients start exhibiting other hypothyroid symptoms, is anxiety. Usually this is a look back. Somebody comes in and we've either diagnosed them with hypothyroidism or they have hypothyroidism, and they're not getting anywhere, and so they show up at our door, especially the autoimmune folks, because the quote unquote real doctors ignore it all and say it doesn't matter. That they have thyroid antibodies and it doesn't matter what they eat, and so those are the folks that show up at our door. So we always go back and see if we can find a triggering mechanism. On occasion, we can pinpoint one, and if we can undo the triggering mechanism, even many years later, very rarely, it doesn't happen often, but at least once or twice a year, we can actually get a quote unquote cure. It's always happened with hypothyroid patients that have autoimmune antibodies with H. pylori. In my experience, I mean, that's the only time that it's happened. So we find somebody that's had an H. pylori or has a positive H. pylori and has thyroid either abnormalities in their labs or thyroid abnormalities in their symptoms. There's a hope that if we go back and retreat them, that we can correct the thyroid problems. Like I said, I've been doing this kind of work for more than 20 years, and we probably had maybe 30 to 40 patients that have been quote unquote cured, and it's always been with H. pylori. So we like to get excited. We get excited. We don't promise anything, of course, because most of the patients don't get quote unquote cured. And when I mean cured, I mean their thyroid symptoms go away. They don't need thyroid medication anymore, and their thyroid labs become normal and stay normal. So subclinical hypothyroidism can also present as a sensory neuropathy, and they get sluggish tendon reflexes also, particularly in the patellar and in the ulnar reflexes. Hormone replacement can help prompt nerve regeneration. Oxytocin, I saw Dr. Halasa came in, so I know he's happy to hear about this, has direct analgesic effects. Pain inputs create a pulsatile production in the hypothalamus, and oxytocin is released in the posterior pituitary. It activates endogenous endorphins, and it binds and activates CNS opioid receptors that can be reversed with naloxone. Oxytocin is ineffective when opioids are on board, so patients will do better with oxytocin that are opioid naive. Oxytocin will activate anatomic signaling blockade, and neuronal projections from the hypothalamus to the dorsal horn of the spinal cord will become stimulated, and oxytocin will prevent pain signals from reaching the brain via this route here. It has beneficial effects on mood and depression, as we know. It's short-acting, usually about 4 to 6 hours. So it's best for short-term non-opioid moderate to intermediate pain. It can be used with over-the-counter products and even ketamine, and the doses are anywhere from 40 to 80 units as a sublingual troche, liquid or nasal spray. We've used oxytocin for appetite control, weight control in a little bit lower dose, and about 24 units twice a day for that, split into.
Yeah, I think what's been changed for oxytocin is that dose, especially for tonight's, we used to do little dose there, like we do 25 or 20 international unit per ml. That's what's valuable. We increase it to 100 international unit per ml. The reason, because when you do spray, each spray has only 12% of that. So,
Right.
and that's the reason now we need to go up to 100 international. So you need to totally have 200 international unit daily in order to manage tonight's.
Right.
That's what I'm trying to say here, according to the recent publication. And that's the reason maybe before we're not feeling the aha moment, the aha moment.
Yeah, yeah. So the key here is you need to get it, use enough. I put in nandrolone. I don't really use this very often. It's it's a synthetic anabolic steroid, but it does have some anti-inflammatory properties to it, and it's used for degenerative wasting and catabolic disease states. It's useful for anemia, osteoporosis, muscle tears, breast cancer, protein wasting of old age, burns, infections, and particularly HIV. In severe intractable pain states, that progresses to a catabolic state, it can be somewhat helpful. So that nandrolone. Ehlers-Danlos syndrome. We had Carol McMakin on last year, was talking about that. So it's a genetic etiology, hyperelasticity, and can result in progressive soft tissue degeneration, and which also includes membranes, tiny nerve fibers, and spinal cord structures. This is usually a genetic issue, and it can result in severe intractable pain syndromes with spontaneous organ rupture that are common. One of our PAs unfortunately has this, and every once in a while she'll turn a certain way and her hip will pop out, and we have to pop it back in for her, and we never know when it's going to happen. And she has this Ehlers-Danlos syndrome. We start to see photophobia, nystagmus, vertigo, tinnitus, balance issues, muscle weakness, dysarthrias, palpitations, irritable bowel syndrome. Complications are including sleep, a catabolic state, hydrocephalus, and arachnoiditis. And again, nandrolone, which we talked about a little bit earlier, just before, indications are weight loss, muscle wasting, and anorexia, and severe weakness. And we can use that a trial dose for up to 2 months. Use it IM 50 to 100 milligrams weekly, or in a Trochet 1 to 3 times a week. Growth hormone, again, of course, in the youngsters, it tells their body to grow. In us more mature sters, it's regrowth of damaged tissue. And you can use this with unexplained weight gain, decreased stamina, labile mood, fatigue, decreased libido. And again, we've talked about this before, executive function. So memory, concentration, the ability to start projects, the ability to finish projects, the ability to multitask. Can you do that easily or not? Flexible thinking, and the ability to complete tasks. So HGH at 0.3 milligrams per day, or 0.8 to 1.2 units if you have it in units. Usually 5 days a week is the dose. Remember, it's FDA illegal to use for quote unquote anti-aging, and it is a great pain reliever. It improves stamina and improves fatigue. It also improves strength, and this is what the athletes got a hold of after the steroids, so they could hit 75 home runs at age 45. Vitamin D3. Vitamin D3 results, low vitamin D3 results in nonspecific musculoskeletal pain, headaches, and fatigue. Chronic pain, the patients usually have chronically low vitamin D levels. Those that are farther away from the equator, and particularly in the darker times of the year, have lower vitamin D levels. We want a therapeutic level. We like 50 to 80. I've seen it 60 to 90. I've even seen it a little bit over 100. You don't want too much vitamin D. An exposure of 50% of the skin without sunblock for 12 minutes at mid-latitude will give you about 3,000 units per day. Vitamin D3 is necessary for calcium absorption and bone strength, and it ensures adequate immune function, brain, heart, and blood vessel integrity, insulin regulation, and mood stabilization. our doses. So for every 1,000 units of a good quality vitamin D, it will increase your 25-hydroxy vitamin D level by about 8 nanomoles per liter. So if you have a patient with a vitamin D level of about 25, remember it's 8 points per 1,000. If you gave them 5,000 units per day, 5 times 8 is 40, plus your 25 baseline, that will get you to your 65. And remember, that's your midpoint. So the normal value for most labs is about 30 to 100. Our optimal value is about 50 to 80. The way we figured the 50 to 80, we found the midpoint. So we take the 30 and 100, add it together is 130, divide by 2 is 65. Remember that 30 to 8 to 100, that's your 2 standard deviations, 95.4% of what we're measuring. That's that sort of universal mathematical model. One standard deviation is 68%. We break that in half at 34% on either side of our midpoint of 65. If you do 0.34 times 65, you're going to get 15. You take 15 away from our midpoint of 65 is 50. Add 15 to our midpoint of 65 is 80. And that's where we get our optimal level of 50 to 80. It works a little differently when we have absolutes. So like C-reactive protein 0 to 3.0 is normal. So we have to calculate it a little bit differently. Anybody who wants those values that we use, let me know. I'll be more than happy to pass along our lab sheets for you. So there's also a 25 and a 50,000 unit time release vitamin D. There's a D2 and a D3. You want to use the D3. That's the one that gets better absorbed. The D2, I think, is the one that is the prescription one. The D3 are the over-the-counter ones. So we've used them. Again, we use, reliable supplement companies. I won't mention them while our CME credits are on. It doesn't translate exactly. So 50,000 units per week would be about 7,000 units per day. It does lose a little something in translation, but it's pretty close. And we've used them quite often. They're very inexpensive. You can get 12 prescription 50,000 vitamin D from pretty much any pharmacy, from anywhere from $8 to $10 for 12 of them. So about 60 to 80 cents to $1. Per week. So they're really inexpensive. You can get too much vitamin D. So vitamin D levels in the hundreds, 120, 150 range, you're going to see patients that complain of tinnitus, ringing in the ear, dizziness, balance issues. They'll feel quote unquote loggy, like their head's not attached. And if there's no other explanation and they're taking vitamin D, it's probably that's what it is. I have one patient. I don't bring this up only because Dr. Gordon, my mentor, the traumatic brain injury mentor, says he takes 50 to 80,000 units a day at sometimes of vitamin D. And he was on there's a Joe Rogan, and he was on that. And Joe Rogan said, wow. And he said, well, why? There's no reason for that. Well, I had a patient in the early 90s. This was before we were measuring vitamin D levels. He was not in good shape. He was 44 years old. He showed up in the ER one night having status epilepticus, which was new for him. He'd already had two heart bypasses. He had stents in his hearts. He was waiting a heart transplant. He was a bad diabetic. He had a half a foot off. He had a stent in his left carotid artery. He shows up in the ER in status epilepticus, and the only thing in all of his labs, all of his X-rays, all of his scans were all normal. There was no tumors anywhere. His calcium was over 15. So usually calcium at that high level, that's some sort of brain tumor or some sort of tumor until we rule out otherwise. But he had nothing. We really had no idea what was the matter with him. And the weather was bad. This was in Wilkes-Barre, PA. We wanted to send him out to Philadelphia or to New York, but the weather was bad. I called his wife and I said, well, we don't know what's the matter with him. And we had every specialist you could think of looking at him. No one had a clue why it was. And what it turned out was, I'll give you 2 pieces of information. A year before all this happened, Sam's Club had opened in our town. And Northeast PA has a rather unique Eastern European ethnic community that sort of survived even to today. And one of the old world customs was that mom puts a candy dish at the stairwell. So at the basement, at the at the stairs and upstairs, puts a candy dish and would put little candies in there, Reese's Pieces and whatever, M&Ms and whatnot. And your reward for going up and down the steps was to take a scoop of candy. Well, our patient here, Tom, apparently went to Sam's Club and bought 6 bottles of vitamin D. Vitamin D in those places have 1,000 pills in them. And I didn't know what the dose was, but if it was a 2,000 unit pill, he took, and his wife tells me he went to Sam's Club and bought 6 bottles of vitamin D 6 months earlier, and then a month before he showed up in the ER, he went and got 3 more, and he only had 1 bottle left. So he took 2,000 unit pills in 6 months, and I estimated it was about 88,000 units a day. That's what turned out to be. We did get a vitamin D level, and all we could get was greater than 900. And he passed away. We couldn't wake him up. We tried plasmapheresis, we tried dialysis, and nothing worked. And he wasn't in great shape anyway, and he did it to himself. But you can get too much vitamin D. And I think 2 weeks ago, there's somebody in England also passed away from a vitamin D overdose. So it's rare, but it can happen. So to summarize, pain is a stressor. Severe pain stimulates the pituitary and adrenal glands to attempt the healing process. It secretes cortisol, pregnenolone, and adrenaline into the bloodstream. Unresolved pain leads to adrenal exhaustion. It results in lower levels of cortisol and pregnenolone. Eventually, you get with this sort of a burnout. Daily opioid administration interferes with testosterone and pregnenolone production. The term neurosteroids applies to hormones secreted in the periphery that cross the blood-brain barrier. Neurosteroids are included that we're looking at here are pregnenolone, estrogen, progesterone, and testosterone. If deficient, results in insomnia, ineffective medication, depression, fatigue, allodynia, and hyperalgesia. Neurosteroids fine-tune the neuroactive steroids. Recurrent pain flares result in pseudo-Cushing syndrome. You get a blast of excess cortisol. Sequelae include hypertension, hyperlipidemia, diabetes, osteoporosis, brain atrophy, and loss of mental function and cognitive function. Severe pain causes reorganization or neuroplasticity of neurons and glial cells and loss of brain tissue. HCG, pregnenolone, progesterone, and testosterone directly and indirectly reproduce neural tissue, with the resulting in less pain, lower opioid doses, less insomnia, and elevated libido. Remember, these are the hormones that we're looking at. If you want to draw them between 6 and 10 a.m., the most important ones are on the left: cortisol, ACTH, testosterone, pregnenolone, progesterone, HCG, and DHEA. This is what you need to ask when you ask your patients for estrogens. You want to ask them if they have hot flashes, night sweats, brain fog, belly fat, memory loss, bone loss, and any type of cardiac symptoms, particularly shortness of breath, squeezing in the chest, anginal symptoms. For testosterone or estrogen excess, they produces cysts, so ovarian cysts, breast cysts, breast tumors, uterine fibroids, and remember, with too much estrogen, gallstones. Breast tenderness. A mammogram will show dense breasts. That's estrogen excess, and usually over time. Patients have anxiety, spotting, cramping, infertility, joint pain, and weight gain, particularly in the middle. For progesterone, usually you're going to find low progesterone, so it's agitation, irritability, poor sleep, panic attacks, poor libido, headaches, and short-tempered. Usually, low progesterone symptoms will go hand in hand with excess estrogen symptoms. Testosterone deficiency is anxiety, depression, poor sense of self-worth, poor muscle tone, urinary incontinence, vaginal dryness or erectile dysfunction, poor libido, poor sexual function. Testosterone levels are inversely related to glucose levels, so adequate testosterone or adequate blood sugar levels Patients that have adequate testosterone levels over the age of 60 will live on average 10 to 15 years longer than those that do not. Too much testosterone, oily skin, oily hair, acne, skin breakouts in the neck and shoulders, road rage. Remember, I told you that was fairly rare. Hypertension, atherosclerotic vascular disease, acne, the thyroid, dry skin, dry hair, hair loss that comes out evenly on the scalp. Remember, male pattern baldness from testosterone issues has a distinct pattern. Fingernails crack and break, constipation, can't lose weight, tired all day long rather than intermittently, that's cortisol. Eyebrows thin out at the edges. Eyebrows that are thin in the center or thick or reflect growth hormone. And in the inner part of the eyebrow, the inner third of the eyebrow, those are the sex hormones. So in females, estrogen and progesterone, and in males, testosterone. So look at patients' eyebrows. If you look at them long enough, you become your own mini endocrinologist. Cortisol, the patient is tired upon rising, needs some sort of stimulant mid-morning. They're exhausted in the mid-afternoon, and it's particularly by dinner time. They get a second wind later at night after 8 o'clock, and then they have trouble sleeping. And there's usually sugar or salt cravings. And if they sit down and relax for any period of 10 minutes or so, they usually nod off. Growth hormone deals with strength, energy, sense of well-being. It deals with executive function. So memory, concentration, the ability to start projects, finish projects, switch between tasks, completing tasks, dark moods, paranoias, obsessive compulsive tendencies. Insulin, too much insulin, you know, that's your diabetes. So excess thirst, urination, abdominal pain, and visual disturbances. Not enough insulin is hypoglycemia. So sweating, tired, hunger, shaking easily. DHEA, pretty much the same as testosterone, prone to infections. Noise. So DHEA deals with noise. Pregnenolone deals with light. So light intolerant is a pregnenolone issue. Noise intolerant is a DHEA issue. Pregnenolone, again, is memory, stress intolerance, salty foods, and things seem dim versus the past. Low prolactin levels. We look at prolactin levels for treatment-resistant anxiety and depression and poor immune responses, and high prolactin levels. Usually, it's a sort of an alarm for a pituitary adenoma. Look at all of the pituitary hormones. Will give you a clue there. Chronic pain leads to an HPA axis overstimulation and adrenal exhaustion. So an intractable pain will stimulate the stress response system, will stimulate the pituitary to cause the adrenal glands to produce cortisol, adrenaline, and pregnenolone. You can get into a vicious cycle of uncontrolled pain. We get a spike in cortisol and get a Cushingoid type syndrome, which, if not addressed, will lead to adrenal exhaustion and a low cortisol or vegetative state. So this is sort of if we don't do anything, this is what's going to happen. These are last two slides are charts, pretty much symptoms. Functions of all of our hormones here in the center, symptoms of deficiencies here. There are dosing suggestions here on the left. So we have testosterone, estrogens, progesterone, growth hormone, thyroid, cortisol, DHEA, pregnenolone, prolactin, and oxytocin. Again, their functions, deficiencies. I have two more charts coming up. Biomarkers, these are percent of positive biomarkers with neuroinflammation. As you can see, C-reactive protein and myeloperoxidase are the two highest, and even those are only positive in a third of patients. I don't usually do a SED rate if I'm doing a C-reactive protein. And then if you get your inflammatory markers, TNF alpha, you can get that here. This is, again, the hormone summary chart, but these are the cytokines that are involved. So your inflammatory markers that are involved, and you can mix and match these with medications, pain medications, supplements that will cover these cytokines that are involved. Here are the references that go with it. And then here are all of our references for what we talked about today. So, and there are 83. So that is what I have to say today. So I'm kind of the moderator too. So anybody have any questions?
Another
Anything in the
fantastic
chat?
job.
Is there anything in the chat? So
I've got a question. It was in the chat. I just asked when I was trying to correct it. I'm curious what if you have an opinion on, say, a 16-year-old female with Ehlers-Danlos syndrome who has urinary and fecal. I put incontinence, but I meant retention to the point where she has to self-path and she has a tube that she flushes so that she can evacuate. So, and that, like, there's nothing. What else could possibly work? So my question is, any thoughts on or your feelings on nandrolone for a 16-year-old female, if that might possibly strengthen or heal maybe it's the laxity of the vagus nerve, you
might want to try a vaginal testosterone. I think you'll get an improvement in the musculature, particularly around the urethra there. Carol, if you're on here, any thoughts on that? But I think vaginal testosterone would probably be, and it'll stay local, so it's not, she's not going to get testosterone at excess. Okay, and you can use low doses. You can use like a 1 milligram per gram, either a suppository or a cream. So I might look at that. I try to stay away from that. And 16 years old, we're going to start her on nandrolone.
Yeah.
We're talking 40, 50 years of this. I have no idea what would happen. Maybe, short term, but I certainly wouldn't want to do that long term. So.
Okay. No, I appreciate your opinion on that because, I'm just searching for answers, and that one sounded extreme. Like, well, I mean, for myself, I thought, gosh, yeah, nandrolone, for Ehlers-Danlos, but for a 16-year-old, I'm going, gosh, I had no idea. That sounds a little extreme.
The other suggestion I might have is, you remember we had Carol McMakin on with her frequency specific microcurrent. She does a lot of electrical stimulation with Ehlers-Danlos syndrome, and we may get somewhere there. So I have her contact. I'll see if I can get her and see if she's got something to add. Okay, but from my standpoint here, you'll I think vaginal testosterone would probably be the way to go. Okay.
Dr. Joseph, could
Yes.
I jump in?
Yeah.
I have a patient with Ehlers-Danlos, and she has POTS and a very complicated case.
The same thing, POTS as well.
She has sought out somebody who was evaluating her for Mayer-Thurman syndrome, which is leads to pelvic congestion because there is an overlay of the inferior vena cava that compresses the vasculature of the iliac vein. So it's Mayer-Thurman syndrome. And there is hope and she's hopeful that she's going to be able to get a stent and be able to relieve that compression and thereby help out with a lot of her GI symptoms.
Okay, so sounds like from that standpoint, it's more of a functional. It's something's pushing on something, and it's
structural. Yeah.
Okay. Thank you. That's great.
I hope.
Thanks for adding that. Thank you. No, I appreciate it.
Thank you.
That's a rare one. Never heard of it.
Yeah.
Somebody asked about serum versus were we done?
Oh, I'm just gonna contribute to Dr. Joseph's case here.
because we see, I'm a practitioner of the shoemaker protocol. So we see a lot of these cases, Ehlers-Danlos cases that are very prone to such symptoms that you just mentioned. And I would check TGF-beta 1 in these patients. And they are highly likely to be high in these patients. And maybe you would entertain the protocol if you get into the, I mean, it's a very thorough protocol. So just maybe look into it if that's something she wants to do.
You're talking about so are you talking about mold toxicity?
Biotoxin illness, yeah. So
Oh, okay. No, that's a great point because the mother and they had requested me for a different reason at the time, just to get my thoughts on the matter. And she basically had said, why didn't they never check for anything like mold, or, how come the functional medicine doc I went to didn't consider, well, I don't think it was functional medicine. I think she was still seeing, sort of the heavy duty conventional, the Mayo clinics, the big places. But yeah, I remember her specifically saying that they never tested for it, and then we lost contact. But this lecture kind of inspires me to check back in and with some of this new information.
Well, let me add something here. Let's find out if your type of Ehlers-Danlos syndrome that you have, it's nonsense mutated genes, because some of them, they are nonsense mutated genes, and we can recover that by using amloxinox, especially type 4 Ehlers-Danlos syndrome, because they're types. So that would be a good way to get into the root cause and possibly restore the gene expression. Do you know the type of the Ehlers-Danlos syndrome the patient has?
It was a year and a half ago, and I actually, at the time, I think we were already uncovering nonsense mutations. I may have already have recommended to try it, and I'm going to check back and find out. My intuition tells me that would absolutely be a part of the plan because of that. That's that one thing that works with the nonsense mutated issues. But also it seems that it's a mild to moderate molecule to begin with. So by itself, I'm not sure it would do the job, but I think in concert with, especially the myothermin, if that is the true issue behind it, that they would work synergistically, it would be a piece of the puzzle. That's my thought.
Did you balance their sex hormones? Did you check their sex hormone and balance that? Did you check the cortisone level? I mean, those things are,
well,
if you can, the balancing as much as you
she's six. Yeah, well, she's 16 years old. I'm not sure
she's
if you
16.
caught that.
Okay.
Yes.
So 16. Yeah.
And at that time, actually, it was about 2 years ago, and that was before I was, at this level and thinking on those terms. But yeah, I'm going to check back, look into the nonsense mutated issue, because I do see more issues when I do get these complex issues and complaints. I do look to see if they are nonsense related, if they've got nonsense mutation related genes. And then there's a part of me that thinks that we have probably more nonsense mutated genes that we think. So it's like, why not?
Yeah,
throw it in
30% of genetic disease are nonsense mutated genes. So we have a lot of disease under that, which I think we need to put a good lecture on that. I missed that part. We need to work together on this, just to list the genetic diseases that has a potential. You can recover the expression of their genes by using the amloxinox and have it the DK enzyme. Yes, but it's type 4. I think that's what they have. I don't know about the other types, but if you can just get to the pathology and get exactly what her type of genetic disease, then at least you can come up with the root cause. And if that's the case, I mean, it's a win-win for everybody.
Yeah, absolutely. And then of course some of the local strategies to try to get.
What about Clotho? I think Clotho would be good for her too.
Yeah, well, that one I would have. I feel like I'd have to think deeply on that because as a 16-year-old, I could imagine that her chlorophyll levels would be quite optimal. Although with chronic disease, it tends to trend downwards.
Yeah,
It's like
test the
it
level of
goes in both levels. But yeah, for sure, it's if anything, it would be worth a try because it's like, okay, she's 16, probably 17, 18 now, and to have to self-cath and to flush herself, it's just, you know, that's there's got to be something that we can do to improve, improve that situation.
So next question, do I prefer serum or salivary cortisol levels? Well, here we are again. So, state of Nevada does not like salivary anything. So we do serum levels to keep them happy. We will do the 4-point saliva testing. You've done that, you all know what that is. You have them give us a specimen when they wake up at noon, 4 o'clock, and at bedtime, and we get that nice graph. And it's good to a good way to sort of dose things when you're trying to straighten out the cortisol levels. But I do serum because I have to. So I don't know if that's a great answer, but that's the answer.
Thanks, Doc. Appreciate it.
Stefan says there's a rapid.
Dr. Clifford, did you remind them, the people here, they can have CME and all that stuff because they may forgot.
I had it at the beginning and I have it at the end of the chat, and I'll put it in again. Also, what I'm doing with these lectures now, I'm putting on our YouTube channel. I'm putting a summary on there, and I'm also putting the link for the CME credits. So far, I haven't been able to figure out how to do it. So you just click on it on the YouTube channel, and it goes right to it. But you can copy and paste it. Okay, so it's on there. The lectures that we did for the last 3 weeks that were CME credits, they're all on there also. Okay, so, and they're good for a year. So you can go back and if you want to get the CME credits. Get a rapid rise in red blood cells after initiation of testosterone seen in sleep apnea. Okay, and then Dr. Halasa says progesterone will help tamp that down. Okay. Stefan has a lecture on landrolone, and we're gonna twist his arm for that. This was the Ehlers-Danlos syndrome. Okay, what level of C-reactor protein is okay? So normal is 0 to 3. Our goal is less than 1.0. And what we do is we follow it along. So we get this pretty much every time we see patients for lab tests. So we'll do it 3 times the first year, and then at least every 6 months after that. And you want to follow the C-reactive proteins, and you want to see whether they're rising or falling. So you get a C-reactive protein of 0.8, and then the next time it's 1.2. It's not going to be flagged at all, but that tells us that we have some sort of inflammation going on, and we want it to, we want it to go the other way. We want to keep it under 1.0. And our go-to here, just to let you know, we use the omega-3 fatty acids, and also curcumin or turmeric. Usually at least 2 to 4 grams of the omega-3 fatty acids per day, and turmeric 500 to 1,000 milligrams twice a day.
You're using HSCRP, correct? High sensitivity?
Correct.
Is that what you mean?
Yep.
Okay, thank you.
Okay. Here's the link for the CME credits, and that one doesn't have a link in it either, so you're going to have to copy and paste that also. Okay, every week it's going to be this https eed.com.em, and the difference is this number here. If you go there, you can make yourself an account, and you have to click 3 or 4 things. Of course, you're going to tell them that the lecture was fabulous. Otherwise, we're going to take your privileges away. And then so you put in an evaluation. It's just clicking. You don't have to do it. It won't take you 5 minutes, and then you can print out the CME certificate. So Doug says the elderly male I told you about has vertigo. Do you see that often? Again, if it's a circulatory problem, if it's an inner ear problem, if his vitamin D level is too high or too low, burning mouth syndrome, with chronic pain, again, yeah. So again, look at the hormones, the ones that we talked about, again, the hormones are not your primary pain control go-to, but this is an adjunct, and you're going to find that the patients will do a lot better when they have optimized hormones. Actually, the question is EPA versus omega-3s. We actually like DHEA better here for pain syndromes. That, and again, at least 1,000 milligrams of DHA. So, okay. Any other questions, comments, complaints? So, I'm going